Hello, my name is Dr. Piyanat Priyanun. I'm interventional cardiologist from Perfect Heart Institute here in Bangkok, Thailand. I have Dr. Christopher Granger with me today. Welcome to Bangkok. And definitely, this is not your first visit to Bangkok, right?
It's not my first visit, but in fact, it's my first visit in many years. And I've had a terrific time, and I especially appreciate the hospitality of your people. It's been a really wonderful visit.
Dr. Granger, what are some of the lessons from the RACE study that are applicable to Asia?
The RACE program is a program that we've led in the state of North Carolina in the United States, in which we've organized the care providers for STEMI in North Carolina to provide a systematic approach to care of STEMI in our state. And I think there's some very important lessons. In fact, and we've seen that at this meeting, which, by the way, I'd like to congratulate Dr. Mehta for an outstanding meeting. Really, I think probably the best meeting ever conducted about STEMI care in Asia. And I'll also say that in Asia, just like in North Carolina where I'm from, and from every other major population source in the world, coronary heart disease is the #1 cause of death. And acute myocardial infarction is the acute manifestation of coronary heart disease. So there are very few things more important to improve public health than to improve the care of STEMI. Preventing STEMI is also important, of course, and in fact, much of the discussion at Lumen has also been about improving not only care of STEMI, but improving care of patients with coronary heart disease and to prevent coronary heart disease. But what we've learned in North Carolina that I think has lessons that are applicable, equally applicable in Asia as they are in North Carolina, is the following. To provide the best care of someone with a heart attack, one needs to have an integrated system of care that involves emergency response by paramedics, by calling 911 and having an ambulance go to the patient. The early diagnosis of the patient, that means ideally having the paramedics have the ability to obtain a 12-lead electrocardiogram. Then to take that information and to use it to diagnose that the patient's having a STEMI and to activate reperfusion, be that fibrinolytic therapy or primary PCI. Ideally, it's primary PCI. In a place like Bangkok, ideally one would hope that 5 years from now, almost all patients in Bangkok who have ST elevation MI get primary PCI. I'm sure you would agree with that. As an interventional cardiologist, that would be the ideal. And I think that's a realistic goal in many cities in Asia, as it is in the United States, where now most patients, but not all. In the United States, we still have major areas where fibrinolytic therapy is the standard therapy. And so we're also sensitive to the needs in Asia. And we've worked on this in North Carolina, that when a person cannot get primary PCI within 2 hours of diagnosis, that then one should get fibrinolytic therapy. But then we've had some good discussions at this Lumen Global meeting about then what? If somebody gets fibrinolytic therapy, what's the best care? What's the best fibrinolytic strategy? And what's the best use of the cath lab and revascularization following fibrinolytic therapy? So those are also important. And then in these STEMI systems of care, one also needs coordinated efforts between hospitals that have primary PCI capability and those that do not have primary PCI capability. So a nice example for example, in Thailand, is if somebody presents to a hospital that doesn't have primary PCI, and let's say that person has had severe hypertension, or maybe a prior intracranial hemorrhage, and they have an absolute contraindication to fibrinolytic therapy, then there needs to be a system in place where that patient can get transferred for primary PCI, even if there's a delay, because that's such important life-saving therapy. Or if the patient gets fibrinolytic therapy and doesn't have ST segment resolution within 90 minutes, then that patient needs to be transferred for primary PCI. And so one has to have a coordinated plan between non-PCI and PCI centers for all patients with STEMI. Sometimes that can be transfer, so if a patient presents to the non-PCI center, they get transferred to the PCI center for primary PCI. And then this network of hospitals then can provide care. And this is something else that's critically important, is that there needs to be a mechanism to measure performance, so that data is captured on every patient who has an ST segment elevation MI to determine how were they treated, what were the times, did they get reperfusion therapy, and then that information can be used to feed back to the system and to identify opportunities for improvement. So these are some of the steps that we've learned in North Carolina are so important, and I think are important everywhere. Number one is one needs to have leadership, passionate leadership, like yourself, like Dr. Mehta, like this meeting is a great illustration of the leaders that exist in Asia to provide passionate, competent, effective leadership to establish best systems for STEMI care. So that's number one, is leadership. Number two is funding. There needs to be some funding, because it takes energy and time and funds to do this. Sometimes that could be from a government. Sometimes it could be from the primary PCI center. But it sometimes may be from insurance, but there needs to be funding to do this. Thirdly, there needs to be a data collection mechanism, a registry, a data collection mechanism, so that one can understand what care is being delivered and improved. We have this saying that I think is really true: if you don't measure it, you can't improve it. So data measurement and feedback is critically important. And then there needs to be a plan in place for each part of the system. It needs to have a plan, and people need to agree what's the right plan, what's the right thing for an ambulance in Bangkok to do if a patient calls with chest pain. Who should get a 12-lead EKG? Can they? If they see STL, who should train the paramedics? If they see ST elevation, what should they do? Where should they go? Who should they call? How can they activate the cath lab? Those kinds of things. And then with all those things in place, then there needs to be the feedback mechanism to constantly improve.
And Dr. Granger, do you feel Dr. Mehta made a good decision of moving the well-established meeting from Miami to Asia?
So absolutely, I think Dr. Mehta made a great decision to move the meeting, and the reason is because there's so much opportunity to take these ideas, this knowledge, these principles, and apply them in Asia in a way which I think will profoundly improve public health and improve the treatment of patients with ST elevation MI and save many lives. So it's very exciting, and I think this is this meeting has been a great validation that if one gets people together who care deeply about improving care, and then gets together the tools that they can use to improve care, that this can make an enormous impact.
Well, Dr. Granger, thank you so much for joining us today.